So with all your due permission, can we begin? It's sharp 3:30.
Yes, sure.
Thank you so much, sir. Good afternoon, everyone. This is Badul from IGCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our keynote speaker doctor for today's session. And he is none other than a very renowned pediatric nephrologist, Dr. Kunal Pai, sir. Sir is MBBS, DNB in Pediatrics, Fellow at Pediatric Nephrology and Fellowship at Pediatric Intensive Care, and Consultant Pediatric Intensivist at Holy Spirit Hospital, Mumbai. With the help of Sir, we'll be taking a close look on today's topic, which is how to identify kidney diseases in children. So before moving on to today's session, let us have a brief look on what the topic says. Identifying kidney diseases in children is crucial for early interventions and appropriate management. Kidney diseases can affect children of all ages, from infancy to adolescence, and can present with a wide range of symptoms or may even be asymptomatic. We'll be learning more about the topic with various methods and considerations involved in identifying kidney diseases in children with Sir's wonderful expertise upon it. So now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. So over to you.
Thank you, Batul. Very good afternoon to everybody. I'll first, at the outset, I would like to thank the IJCP and Batul for organizing this talk, and to all of you as well, because it's 3:30 in the afternoon, and on a Saturday afternoon when everyone's at their lunches, everyone would just prefer to sleep off. But now that you've decided to attend this talk, I'm very grateful. So without wasting any more time, let's begin. So my topic is how to identify kidney diseases in children. So when we hear this question, the first thing that comes to a layman is, do children really have kidney problems? Because we've been always thinking that kidney problems is a problem of the adults, right? But the reality is that kidney diseases do occur in children, and it's occurring more frequently than you think. The only problem is that we don't know that they exist. Identification has been a problem. It's been happening since ages. And if we go to the history, it's not something new like COVID, which was generated, created, no comments on that, but kidney diseases have been occurring since ages. So when did we realize that these kidney problems existed? So if we go back to the historical papers, the first time that a kidney disease was identified, the symptoms were identified because of it being due to the kidney, were edema. And it was found to be that this edema was because of proteinuria. And it was found by this gentleman, Dr. Richard Bright. He's a British physician. And in the year 1827, he first identified that kidney diseases were the cause of edema in adults. So this is for adults. In children, it took another 80 years. So in the beginning of the 20th century, the first identification of kidney diseases happened in children. And the first disease to be identified in children was AKI secondary to dehydration. This AKI is acute kidney injury. Basically, the kidney starts failing because of dehydration. Children were given IV fluids and this kidney failure was treated. And the second disease to be identified was nephrotic syndrome. But nephrotic syndrome could not be treated till the end of World War II, when we started having medicines like ACTH and steroids. Before that, those children were just not being managed as they should have been. So why is identification of kidney diseases so important? Why am I stressing so much? Because first of all, people don't know the actual functions of the kidney. Kidney functions are much more than just production of urine. They include controlling BP, electrolytes, bone metabolism, and many other things. Symptoms are very vague. Sometimes even doctors are not able to actually identify, is this problem because of a kidney disease or something else? And in the early stages, you might actually require tests to identify because the symptoms are so vague. And you should also remember that having two kidneys is a double-edged sword. Why I'm saying this is, we have two kidneys, that's the best part. And if one fails, we have the other one, and you can live a normal life with one normal functioning kidney. The bad part is that because that one good kidney is working, until it fails more than 50%, we would not be able to get any signs and symptoms. So your kidneys might be failing slowly, but your symptoms won't come out that early. Once your symptoms start coming out, that's when it's too late. So that's why early identification of kidney diseases is so important, because if you identify early, you can intervene early and you can reverse the process if it's possible. So moral of the story for doctors and patients is be alert. So before we go to the signs and symptoms, when we are talking about identification of kidney symptoms and signs, how early is too early? Is it before birth? Is it after birth? Is it at 1 year of age, or is it at 10 years of age? We are in the era of USGs, CT scans, MRIs. So because of this technology, we should take all complete advantage of all these modalities which we have. So before we go ahead, let's understand the urinary system. So here we have, so this is the kidney, this is the pelvis, this is the ureter, this is the bladder, and this is the urethra. So the kidneys produce urine. It goes to the pelvis, through the ureter, it goes to the bladder, and then through the urethra. Now, because of such good USG machines, antenatal scans are able to pick up a lot of diseases. So when the kidney is involved, if the kidney parenchyma is involved, we are able to identify diseases like ARPKD, which is autosomal recessive polycystic kidney disease, where both the kidneys are completely cystic and malfunctioning, or we can identify MCDK. MCDK is multi-cystic dysplastic kidney, where one kidney is not properly formed, but the other one is normal. The advantage of this is that once parents see reports which say that both the kidneys are cystic or one kidney is cystic, parents just go crazy. I mean, they're very anxious, and the whole pregnancy, the mother, the father, the grandmother, the grandfather, everybody is in stress. If we are able to identify these diseases early, like if we identify ARPKD early, like in the second trimester, before 20 weeks, we can counsel them for MTP. And at the same time, if we identify the child as an MCDK, we can counsel them that don't worry, the other kidney is functioning normally. So I don't think that this child will have any problems in future if you take care of that kidney. So basically, early identification, we can counsel the parents during pregnancy. Otherwise, parents just go to Google, read something, and they'll get half information, and then it'll spoil their whole pregnancy. The other urological diseases which we can identify is PUJ obstruction. If there is an obstruction at the level of the pelvis and the ureter, then there can be swelling in the pelvis, which is called hydronephrosis. We can also identify vesico-ureteric reflux. That is, if the urine is coming from the bladder and going up into the ureters, that can also be identified. Or we can identify posterior urethral valves. This is very important. If there is a blockage at this level because of a valve in the urethra, then we can identify it, and we can counsel the parents as to what would be the outcome of the child after pregnancy, and that it's a surgical emergency which should be tackled as early as possible. Because usually if parents don't know that the child is suffering from posterior urethral valves during pregnancy, and after pregnancy we waste a lot of time, then if those kidneys could be salvaged after pregnancy, that will also not be possible. So early identification is important here. So what are the signs on USG which we see during pregnancy? The radiologist would usually comment that the kidneys are bulky. Bulky kidneys could mean either the kidneys are cystic, or they could be bulky because there's obstruction in the urinary pathway, or you could see cystic kidneys, or you can see swelling in the pelvis and the ureter or the ureter, and you can see low or high amniotic fluid volume. So low amniotic fluid volume is just an outcome because the kidneys are not producing enough urine, because the amniotic fluid is the child's urine. So if the kidneys are not working, it will not produce enough amniotic fluid. If the kidneys are producing more amniotic fluid, it could signify that the child is suffering from diseases like renal tubular acidosis or Barter's syndrome, where the kidneys produce a lot of urine. So this could also be an indicator that after birth, the child could be suffering from this disease. And thickened bladder wall. Thickened bladder wall is basically an outcome of the posterior urethral valve. Because of the blockage, there is so much high pressure in the system that the bladder walls become thick. What are soft signs? Soft signs are basically findings which the radiologist sees on the sonography. It doesn't mean that the child has a kidney disease. It could also be because of involvement of some other system, or it could just be a finding. Need not always be something like the child having a congenital problem. There could be increased nuchal translucency. There could be an absent nasal bone. There could be echogenic focus in the heart. There could be an echogenic bowel. Echogenic focus means a bright spot in the heart, and echogenic bowel means that the bowel is looking brighter than usual. Or shortened long bones. Or there could be a cyst in the choroid plexus in the brain. This need not mean that the child has an abnormality. It's just a soft marker that maybe after birth he or she might have some problem. We just need to investigate that. It can come out to be normal. Or ventriculomegaly, that is, the ventricles in the brain are larger in size. So now we come to the symptoms. So before we proceed, if we classify the symptoms in separate categories, our identification becomes very easy. So the first symptom that we categorize is appearance of the urine. The color of the urine is a clear indicator of maybe what could be the problem in the kidney or the urinary system. The urine stream, how it is, it's a good stream, a bad stream, and the sensations associated with passage of urine. That's also very important. Is there any pain? And when I mean pain, it's not while passing urine. It could be anywhere in the abdomen, in the back. And swelling related symptoms. Where are the swellings? In the leg, eyes, stomach? We'll come to that. And lastly, generalized symptoms. Generalized symptoms is important because it could also mean it could be because of another system, not necessarily because of the kidney. So we need to figure out whether it's because of the kidney or not. That's why I've kept it to the last for discussion. So now blood in the urine. So now this is how blood appears in the urine, and it's the most scariest thing for a patient. Whenever a patient sees blood, it could mean something as simple as the child has eaten something and the food has some red coloring agent, or it can be as lethal as a cancer of the urinary bladder. But in between that, there are simpler things like a urinary tract infection, could be a kidney stone, could be glomerulonephritis. You don't know. But blood in urine can mean a lot of things. So it needs to be investigated. Turbid or frothy urine. Turbid urine looks like this. It means that the urine which is clear appears much more hazier, and frothy urine appears like the urine is full of bubbles. Turbid urine could mean that the child has a urinary tract infection, or could be because of leakage of proteins into the urine. Now that is something bad. Or it could also mean because of debris released into the urine because of a stone, or because the kidney is losing a lot of calcium. And frothy urine could be as simple as the child passing urine with a lot of force, creating those bubbles. Could be because of the detergents that we are using in the toilet, or could be because of protein leakage in the urine. So turbid and frothy urine should not be missed out and should be thoroughly investigated before we come to a diagnosis that it's not because of anything lethal. Debris in the urine. So debris in the urine, as I had said, could be because of calcium being lost from the kidneys into the urine in a condition called hypercalciuria. Could also be seen in kidney stones, can also be seen in urinary tract infections at times. And high colored urine or dark urine. So this is the most common thing that we observe in our children. So high colored urine could mean as simple as the child having multivitamins because the urine looks dark yellow. Could be because the child has not had enough water because he's dehydrated, or child is having a lot of loose motions and diarrhea, or loose motions vomiting. So because of which the urine appears dark because the child is dehydrated. It could also mean because the urine is appearing yellow because if the child has some jaundice, that bilirubin can leak into the urine and give the urine a yellow appearance. So yellow urine does not always mean it's because of the kidney. It could be because of some other organ as well. Coming to the urinary stream related complaints. So what are the sensations that the child perceives while passing urine? So painful urination is one of the most common complaints. Could be because of a urinary tract infection. Could be because of some drugs like chemotherapy, which can cause cystitis. Could be because of a kidney stone. So it needs to be evaluated as urgently as possible. Straining. Now straining means that the child is standing in front of the toilet and using a lot of force to pass urine, but no urine is coming out. That means that the child has some obstruction in the pathway of urine, and the bladder is trying to push against that obstruction, but the urine is not going ahead. Could be because of an untreated posterior urethral valve, could be because of a stone, needs to be investigated. In adults, could be because of a prostate cancer or just a prostate hyperplasia. But in children, the causes need to be investigated thoroughly. Because if we don't treat this straining, it could lead to back pressure changes in the bladder and could lead to reflux affecting the kidneys. Urgency and urge incontinence. So here I'll first explain what is urgency. Urgency is that the child has just passed urine, and after passing urine, the child doesn't have a completely satisfied sensation that he's passed urine. And again, after 5-10 minutes, he wants to pass urine again. And urge incontinence is that the child has a lot of sensation of passing urine, but the child is unable to reach the toilet. And in between the path where the child reaches the toilet, the child has passed urine in the pants. So these symptoms could mean because of an overactive bladder, could be because of a urinary tract infection. So treatment is essential because it causes a lot of discomfort to the child. Hesitancy. Hesitancy is also similar to straining, seen more in adults, also seen in children. It's basically the person is standing in front of the toilet, but unable to pass urine in spite of using a lot of pressure. A few drops just come out, signifies a bladder outlet obstruction. And last is overflow incontinence and poor stream. So basically, this happens when the bladder is very weak, a hypotonic bladder. Could be because of a bladder issue or could be because of a neurological issue because of which the bladder is hypotonic. So in this, basically, the bladder starts filling up but it's unable to evacuate the urine because it's hypotonic. After a point, the bladder decompensates and the urine just comes out because it's overflowing. And this flow of urine is not with a force, so the stream is also poor. It's just a leakage of the bladder. And bedwetting. Up till the age of 6 years, bedwetting is considered normal. But after 6 years, it needs to be treated. Because number one, could be because of something pathological. And also, if we do not treat bedwetting early, it could have psychological implications on the child's health. Now, we've talked about the colors of urine. We've talked about the sensations associated with urine. Now, what are the sites of pain suggesting kidney diseases? So number one could be in the lumbar region, the lower back below the 12th rib. It could signify that the patient has a pyelonephritis or a UTI. It could be in the hypogastric region, which is below the umbilicus. This could signify that the child has some cystitis. It could be a loin to groin pain from the back to the front. This could signify a ureteric stone. Coming to where can there be edema, as I talked before. So edema can be everywhere, but the point is we need to identify, is the edema because of a kidney disease or some other system? Because a heart disease can also cause edema, a liver disease can also cause edema, allergies can also cause edema. So how does the edema in a kidney disease present? So in kidney diseases, the edema starts from the eye. The person wakes up in the morning and his eyes are puffy. As the day progresses, the edema decreases. By evening, it appears as if the child has never had edema. That's how a edema of the kidney disease is. It can then progress to involve the legs. It can also involve the tummy, which is called ascites, or it can involve the whole body, which is called anasarca. But the eyes is the earliest. If it's because of the heart, then the edema is more in the legs. And if it's because of the liver, it's more in the stomach. It's the abdomen. And if it's allergy, it's generalized always, if it's a very severe allergy. So coming to generalized symptoms. Now, this is important because this is why kidney diseases are called a silent killer, because these signs and symptoms might mimic something very simple in the initial stages, but once we pass that critical period, then it's too late, to identify it. And that's why we need to use up clinical acumen at this point, that is it because of a kidney disease or not? So poor appetite. Poor appetite is one of the most common symptoms of kidney failure. It could also be because of some nutritional issues, could be some other diseases also. What we need to know is that if we are initially trying to treat our patient by the routine protocol of improving the iron, the calcium, the vitamins and all, but the patient is not improving, that's when we should realize that, okay, this is something could be a kidney related. So first we try to treat the basic conditions. We don't just jump that to the conclusion that poor appetite is because of a kidney disease. We should first rule out the most common causes first, and then come to a conclusion that because the common causes are not being treated well, are not being treated, in spite of being treated, the appetite is not being, then that could be one of the reasons why it could be because of a kidney disease. Poor appetite leads to poor weight gain and height gain. And that's why poor appetite, weight gain and poor height gain should be considered as a group of symptoms which need to be looked into if they are not getting treated as per routine protocol. Now coming to hypertension, what does the kidney have to do with hypertension? Kidney has a lot to do with hypertension. Once the kidneys start failing, the blood pressure starts going up slowly to a point that you might require 1 antihypertensive medications, 2 antihypertensive medications, 3 antihypertensive, could be 4, 5 also. Why is this so? Because the kidney is in control of a blood pressure system known as the renin-angiotensin system. And once the kidneys start failing, this system starts going out of control. So that's why we need to have proper functional kidneys to maintain our BP. So hypertension is one of the signs that it could be because of a kidney disease, especially in children. Adults, the causes are different, but children having hypertension is one of the leading causes that it's because of a kidney disease. Bony deformities. The kidney is one of the sites where vitamin D production happens. And because of kidney failure, the production of vitamin D decreases, because of which the child can have bony deformities because of rickets. So that's why child having bony deformities is a clue that the patient could have a kidney disease. Anemia. One of the other functions of the kidney is production of blood. The kidneys secrete a chemical known as erythropoietin. This erythropoietin stimulates the bone marrow to produce blood. So if the kidneys start failing, this erythropoietin is not secreted. And if it's not secreted, it does not stimulate the bone marrow. And because of which there is anemia. Along with that, with kidney failure, there's increase in the levels of urea and creatinine in the blood. Urea suppresses the bone marrow as well. So that can also cause anemia and can lead to significant pallor. So now that you have identified these problems, what should you do? Because how do you proceed here? So the first thing is early referral to a pediatric nephrologist, because when you have a kidney disease, you just don't have a kidney. You have a lot of multiple things, like you can have acid-base balance issues, you can have electrolyte abnormalities, you can have blood pressure abnormalities, you can have kidney failure. So you need to sort out all these problems. So better refer to a pediatric nephrologist early so that identification is early. Sometimes patients might have glomerulonephritis and which might need an early kidney biopsy and treatment with steroids. So better refer early. You can take a history and an examination to get a clue exactly what is happening. And a baseline evaluation can be done, which includes a CBC, a urea creatinine, electrolytes, urine routine, urine protein creatinine ratio, a USG abdomen if required. With this evaluation, you can come to at least 90 to 95% cases, you might come to at least the diagnosis that it's because of a kidney disease. And once you come to know that, you can at this point refer to a pediatric nephrologist so that the patient doesn't go out of hand. And that's all. I mean, this was mainly a more of a clinical based topic because we need to identify patients clinically. Based on lab reports, you can always identify a patient with a kidney disease, but identifying it clinically is more important because that's when you identify the patients early. Once you identify that, then your lab reports are going to give you some clue as to where this patient is heading. And this is the baseline evaluation what we require. And once that is ready with us, then we can proceed ahead with higher tests based on what exactly the disease pathology is. thank you so much for this opportunity. I just like to say at the end that I have my channel by the name of Dr. Kunal Pai, and I have talked about this topic in a video over there. It's in Hindi. It's mainly for the patients. You can please go have a look. And if you have any queries, you can contact me on my email ID, drkunalgpai@gmail.com. Thank you so much.
Thank you so much, sir. Thank you for such a wonderful talk on the topic that you have pondered today with us. So thank you so much for sharing your expertise with all our viewers who were here with us. And I would like to thank all the viewers for their patient listening that they were here for. So thank you so much to all of them. We haven't received any questions, sir, but we have received a lot of feedbacks and people are waiting for your next session on something interesting like this that you have shared today. So they are looking forward for that. So I would read out some of the feedbacks from some of the participants, like Dr. Preetham from Kolkata has given, sir, very nice presentation. Thank you so much for sharing it with us. It will definitely help us. Thank you. We'll be looking forward. Thank you so much, Dr. Preetham, for your valuable input. Dr. Neeraj from Noida has written, sir, I was looking forward to this particular talk from a very long time. Thank you for conducting it so well. We have received what you have given your expertise on. So thank you so much, Dr. Neeraj, for your wonderful experience that you have shared on us with us. And definitely, we also will be looking forward to have another session with Dr. Kunal. So thank you so much. With this, sir, we can conclude the session here for today with all your last comments, and we will be looking forward for another session from you.
Thank you so much. Thank you. Thank you.
Thank you, sir.
Yeah.